Okay. So let's start with the lumbar transforaminal epidural steroid injection. This is one of the most common procedures that's done by the pain physicians. So the clinical picture that we already know that if it is involving the L5, it goes towards the grade 2. If it is involving the S1, it is going towards the little finger, whereas L4 is slightly above and L3 is further more above. So based on the area where the pain is occurring and the pain nature should be a neuropathic nature, you can say L3 pain area is the front of the thigh of the knee, whereas sensory loss in the medial portion of the thigh of the knee, and there will be paresthesia at the same area, and quadriceps, iliopsoas and hip adductors will be affected. And in L3, the patellar reflex as well as the adductor reflex is both affected. Whereas L4 affecting again the medial portion of the leg, and it actually causes motor disturbance in the antitibialis anterior, quadriceps and hip adductors, and that is mainly responsible for the patellar reflex. So if this L4 root is affected, then it will actually stop this patellar reflex. Next, coming to the L5, this is one of the most common. L5 and S1 is the most common origin of pain. So it affects the lateral portion of the thigh, leg, dorsum of the foot, and then sensory loss goes to the lateral portion of the leg, dorsum of the foot, and the first toe. And here the grade 2 is mainly involved, and extensor hallucis longus, that is the two extensors and flexors, ankle dorsiflexors, eversion and inversion of the ankle hip adductors. So multiple muscles are involved, but it is not specifically associated with the reflex. Whereas the S1 is goes from the posterior portion of the thigh and heel, and sensory loss occurs in the sole of the foot and
Sense.
two most lateral toes.
Same,
Okay,
ওখানে তো স্টাইলিং দরকার নেই
paresthesia
আমার শুধু
will be at the sole
বুঝতে
of the foot, lateral toe.
হুম
Someone is talking, so let me mute all. Okay, okay, now I think it is fine. So here what happens, the one of the important area is the weakness of the gastrocnemius, biceps femoris, gluteus maximus and the toe flexors, and which is affecting the Achilles reflex. So remember, one thing is very important, especially regarding the heel walking and toe walking, that we ask usually the patients of lumbosacral radicular pain to try. That is, it has been found that if the patient is having the involvement of the S1, usually the toe walking is affected because the plantar fractures are affected. Whereas in L5 affection, what is happened when the L5 is affected, then it is the hill walking that is more affected. So based on the which is more affected, whether it's the hill walking or toe walking, we can try to make a guess at which level may be involved. So it's definitely clinically. Now coming to the clinical evidences of the procedures. So it has been found that in certain conditions, transforaminal epidural injection is beneficial, especially for the content herniation, where the grade of evidence is 2B+, whereas the intralaminar corticosteroid administration is also having a comparatively high evidence, whereas the other cases, for example, past radiofrequency treatment, close to the spinal ganglion or the radiofrequency ablation at the level of the DRG, which goes a negative recommendation. Spinal cord stimulation for the failed back surgery syndrome, it goes a very high level of evidence, 2A plus, and adductolysis or epiduroplasty is a comparatively intermediate. So you can say it can be done only related to a study, but it should not be related routinely. So these are the evidence level. Now coming to the clinical practice algorithm. That further for the lumbosacral radicular pain, we should be going every time for this type of procedures? The answer is no. Definitely, first we have to rule out the red flags. If there are red flags, you might think of a surgical treatment beforehand rather than going for this. Now coming to the conservative management. Now what conservative management do you usually prescribe? Usually the common conservative management that is prescribed for the beginning is definitely paracetamol and NSAIDs for the management of pain. Then along with the paracetamol and NSAIDs, we can add two group of medicines. One is the anticonvulsant and other one is the antidepressant. Usually it has been found that amitriptyline and nortriptyline among the older drugs, that is the tricyclic antidepressants, is good for the management of this kind of pain. And usual dose is about something between the 10 to 50 milligram for amitriptyline and nortriptyline, whereas the selective serotonin norepinephrine reuptake inhibitors like duloxetine can also be prescribed here, and usual dose is between 20 to 50 milligram. So you have to be choose according to the patient's condition. For example, if the patient is old, we should prefer a newer drug instead of amitriptyline, because that can cause certain problems like urinary retention, like sinus tachycardia, or management of hypertension can be hampered. So in those cases, based on the age and other conditions, we have to select which drug to give. Among the anticonvulsant, two drugs are very popular. One is the gabapentin and another is the pregabalin. Now, regarding the difference between the gabapentin and pregabalin, there is not much difference. They are of the same group. They are acting on the centrally acting alpha D2 receptor. But the difference is that the sedative property for the gabapentin is slightly more than the pregabalin, though it is written in the every book. But in my clinical practice, they are not much different. Next, the absorption of the pregabalin is more predictable than the gabapentin. Gabapentin absorption may be sometimes erratic, so sometimes dose adjustment may be a problem. And usual equivalent dose is that 75 milligram for pregabalin is equivalent to the 300 milligrams of gabapentin. And usually for most Indian patients, we start with a lower dose. For example, if you are thinking of pregabalin, usually start with a 25 or 50 milligram, then gradually escalate the dose, and moderate dose escalation usually commonly required for the Indian patients is 150 to 300 milligram. In certain cases, we might go up to 600 milligram of pregabalin. Similarly, for the gabapentin, though the book says much higher dose up to 2400 milligram is written there as a dose, but in most of the cases, what we prescribe is usually in between the range of 300 to 900 milligram. Usually start with a lower dose, 100 milligram at bedtime, or sometimes 200 milligram at bedtime, and then gradually increase the dose to up to 600 to 900 milligram. That is usually required in most of the cases, but depending on the patient's tolerability and the effect as well. So in some cases, if the prolapse is mild, and sometimes maybe 100 or 200 milligram is good enough to manage the initial pain, and for certain durations it can be healed spontaneously. But if the conservative management is failed, okay, and in conservative management, I forgot to mention the another part also. If it is not being managed, then you can use the opioid also. For example, tramadol or tapentadol can also be used along with the paracetamols and NSAIDs. But remember, while giving tramadol, you should keep off serotonin syndrome, because the antidepressants as well as the tramadol act in the same mechanism of reuptake inhibition of the serotonin, and which can cause a dangerous level of the serotonin in the nerve endings and leading to the serotonin syndrome, which could be dangerous. That is why if you are mixing these two drugs, if it is a low dose, it doesn't cause much problem. But if you are giving both of them in higher doses, you should be very, very careful. But remember, in pain, we usually go for the SNRI or SSRI, or SSRI we don't commonly use, SNRI or TCS in a comparatively lower dose. So it doesn't cause us problem in most of the routine cases, but that you should keep in mind. Now coming to the conditions when the patient is not responding with these drugs, then what are the options? Whether it's a chronic problem and subacute problem. Based on that, usually your treatment differs. For the subacute problem, usually the best option is the transforaminal epidural steroid injection. For the chronic problem, definitely you can use the transforaminal in those cases also, but the better option in certain cases is the DRG stimulation with the pulsed radio frequency. That gives sometimes better result in chronic patients, but definitely in most of the cases along with that we go for the transforaminal as well in case of chronic patients. And if the result is good, then definitely we should continue that, and in most of the cases the result is good, average to good. And if the pain is not responding, then you can go, if for failed back cases, you can go for the uh, SCS or spinal cord stimulation. And in some cases, if there is adhesions, then you can consider the adhesiolysis or epiduroscopy in such condition, and definitely it should be done in the specialized centers, but these facilities are available. Now coming to the corticosteroid. Now the question sometimes comes, why corticosteroid? What it does and why it is advantageous. Remember, for most of us, the concept is that when there is a mechanical compression over the nerve and that is causing the pain, then what is the problem? What is going to do with the steroids? Remember, in this neuroforamen, only one third of it is having the nerve. The rest of the area is having the fat, epidural fat, and there are also capillaries, and some potential spaces are also there. So what happens in case of inflammation in radiculitis? So basically there are a lot of inflammation at the root. So in a number of cases what happens, it is not the mechanical compression that is the main culprit, rather the inflamed nerve root and the inflamed areas and adjacent tissues, they put a pressure over the nerve. And remember, it has been shown that the long-term benefit and another short-term benefit. So there are mixed results, but in a number of cases, it has been shown to have a very good result. So what it does, first of all, a transforaminal epidural injection, steroid injection helps to wash off the inflammatory exudates from this area, and also it reduces the inflammation in the nerve root and adjacent area, giving the room to breathe for the nerve, and actually which is helpful for the pain relief, not only in the short term but also sometimes in the medium and long term as well. Now, indication for the transforaminal epidural steroid injection. First of all, it is the lumbosacral radicular pain. So, whenever there is pain, which is typically the lumbosacral radicular pain, and when the standard treatments fails, like conservative management, physiotherapy, or sometimes the exercises, so they failed, then we should consider the transforaminal epidural steroid injection for relief of the radicular pain. Then we can use it for the degenerative disc disease. Remember, in degenerative disc disease, the pain relief period after the transforaminal epidural steroid injection is comparatively less, and it can occur and reappear as well, but in a number of cases, this also gives a very good result. And for the spinal stenosis, we have tried it. It gives a short-term relief, but it is not very long-term. Next, coming to the contraindications. So, among the contraindications, first, allergy to the injected. For example, if the patient is having the allergy with the lignocaine, or the patient is having allergy with the bupivacaine, based on the which drug is the patient having allergic, you have to avoid it. Number two, if there is any systemic or local infection. So at the area through which you will be going, if there is infection, you should not be doing, or the patient is having sepsis or systemic infection or other conditions like patient having fever. So in those cases, you should avoid. Then patient having uncontrolled bleeding disorder or other medical conditions that is do not allow for the safe performance of the procedure, then we should always stop this procedure. Next comes to the pregnancy, again a relative contraindication because we cannot use the fluoroscopy there. So that is a relative contraindication there. Then if there is a anatomical concerns, for example, the patient having cancer tumor at that area, or there is a well distorted anatomy which actually hampers the safe performance of the procedure, then also that becomes a contraindication. And when the patient is not psychologically or psychological problem is there, patient is not giving consent, not allowing to do the procedure safely, that is also a contraindication for this condition. Now coming to the which posture we should do. So usually it is done in the prone position with a revolution table with a pillow below the abdomen. Remember, in a normal condition, what happens? Usually the spine is having a lumbar lordosis. And if there is a lumbar lordosis, there is a problem that the posterior elements are usually together. So what happens? We have to stretch the posterior elements by putting a pillow below the abdomen. This basically helps to reduce the lumbar lordosis so that we can get a more space to enter to the foramen and to the area where we need to perform the procedure. And then after positioning the patient, next part comes in the skin sterilization with betadine or chlorhexidine. Sometimes you can use the spirit as well. Depending on the protocol of your institute, you can actually go for the skin sterilization. Use a sterile drip and a cut sheet to actually we should bait it at the area. Now you have to locate it. So first for the location, we have to go for an AP view and find out at which level you are going to do the procedure. Now after you have located the area, Next thing is the preparation of your drugs. So what are the drugs required? First of all, for local anesthetic, most commonly what we use is the preservative-free lignocaine. Remember, if you are giving only to the skin and subcutaneous tissue, even with preservative works, but if you are going to the nerve, it is preferred to have a preservative-free lignocaine either in the form in India, either in the form of a Loxicard or Xylocard, and then we will be requiring a normal saline, definitely for dilution of the drugs. Triamcinolone, now it is most commonly used for the transforaminal epidural steroid injection. So 40 to 80 milligram triamcinolone is required. Then we require a non-ionic contrast agent, and commonly used is the Omnapec, and also we use a steroid. Okay, so already I have told you either triamcinolone or dipomethylprednisolone. Regarding dipomethylprednisolone, there was an old case for which nowadays we prefer using the triamcinolone more than dipomethylprednisolone. But yes, we have used the both for long and without much complication. But remember here, initially during the COVID period, as the China was the main source of non-iodide contrast agent like iohexol, so there was a shortage of the iohexol. So what you have found that the gadolinium based contrast can also be used, though again now it is available, so no one uses that again. Now coming to the initial X-ray. So how should you should put the X-ray and how you should change it and align. First, try to get an AP view. And after getting an AP view, the next job is to find out the level. So once you have found out that from the MRI that this L45 is affected. So we have to go at the L45 or L34 depending on at which level it is affected. We have to find out that level. And next step includes the squaring of the vertebra. Now the concept is you have to make it clear that what is squaring. Remember, let me draw a picture. So when you see an object, for example, we are seeing this. Okay, this is the body of a vertebra. Then we are seeing this. This is the body of a vertebra. So what is the difference between these two pictures? So remember, the actual shape of the three-dimensional of a vertebra will remain like a kidney shape or like a cylindrical shape, and there both sides will be oval and this will be the sides. For example, if you look at, let me clear this big drawing and then look at two bones. So if you look at this vertebra is looking like a square. But if you look at this vertebra is looking like a cylinder. So it is not about the vertebral property. Both the vertebrae are the same, but one is looking like a square, one is looking like a cylinder. The reason behind that is that at which angle through these end plates the X-ray beam is going. When the X-ray beam is going parallel to these end plates, it will look like a straight line. And when the X-ray beam will be going obliquely along the end plate, it will looking like a square. Sorry, it will looking like a oval. So remember, this is a cylindrical area, cylindrical, and this is square. So remember, we usually commonly say what we need to do at the level at which we need to perform the procedure. We need the squaring of the vertebra. So what we do in the name of the squaring, we basically change the anteroposterior orientation. So what we are doing either a cranial tilt or a caudal tilt of the C-arm to make the end plate parallel. And that is we what call as the squaring of the vertebra. So after the first part, that is finding the level and finding the side, then we'll be going for the squaring of the vertebra at the level at which we want to perform the procedure. So that is the next part. So take an initial X-ray to locate the area of the interest, then use a sterile marker to on the skin. Definitely we'll be using a sterile marker for the entry, and that will be using on the screen. Now in the next step, what we have to do after we have done the squaring at the desired level, in the next step, we will position the C-arm from anteroposterior view to an oblique view. Okay. So in the anteroposterior view, it was looking like this. but after the squaring, okay, now when we have made it oblique, it will look like this. Okay, it will look like this. Now the question comes, how much oblique we should go? From the squared view, how much oblique will go? So first step I have already told, squaring of the vertebral end with the cephaloid or caudal tilt, then oblique the C-arm to the affected side. But how much oblique? Usually it is said that the spinous process of the vertebra will be matching the opposite facetal axis. So remember, these are the facet joints, these are the facet joints, and when we'll make it oblique, the spinous process of the vertebra should match with the opposite facetal axis. And this shows a very important feature in the spine. So what is that? That is known as the Scotty dog or the Scottish dog appearance. When we make it oblique after squaring, we can imagine a Scottish dog here. So it is the ear of the Scotty dog. This is the eye of the Scotty dog. This transverse process is the mouth of the Scotty dog. Then this is the pedicle, again, which sometimes called the eye of the Scotty dog. This portion, that is the inferior articular process, becomes the front limb of the Scotty dog. Then the opposite sided transverse process becoming the hind limb of the Scotty dog. Then that opposite transverse process becoming the tail of the Scotty dog, and the neck is formed by the pars intra-articularis of the vertebra. So that is how we find the Scotty dog. And remember, this Scotty dog is very useful, and you have to identify it in the oblique view of the spine, and without this doing a safe procedure, mostly the lumbar procedure is almost impossible. So this is the primary step to understand the Scotty dog. So if I delete the Scotty dog, can everyone see the Scotty dog right now? So it should come from your imagination. Can everyone see?
Yes, sir. It's
Okay.
visible.
The Scotty dog you should be able to identify. Then after finding the Scotty dog, then we should take an opaque object on the area where we have to go to the spine. So for example, what we have to do, for example, there are two ways for doing a transforaminal epidural steroid injection. So this is one pedicle. So below the pedicle, this is an area. This is known as the subpedicular area. Then we have the superior articular process here. And by the side of the superior articular process, so I have to mute again, unfortunately. Mute all. Okay. So by the side only, by the side of the superior articular process, we have an area. This area is known as the Kambin's triangle. So I will come what is Kambin's triangle. So let us draw an imaginary nerve. For example, the nerve is coming at this level like this. Then it is forming two imaginary triangle, one above the nerve. This is one triangle, and one below the nerve. Okay. So two triangles are formed. Now, if I draw these two triangle, this is one, this is another. So one that I have drawn in the red above is known as the safe triangle. And that what I have drawn above below, it is the Kambin's triangle. So what are the boundaries of the safe triangle? So upper boundary of the safe triangle is the lower end of the pedicle. The lower boundary of the safe triangle is the imaginary nerve, or in reality it is the nerve, and the line joining the lateral border of the pedicles, that is the third arm of this safe triangle. And where is the boundary of the other triangle? That is what is the boundary of the Kambin's triangle. So the medial boundary is formed by the superior articular process. The upper boundary is formed by the imaginary nerve, and the lower boundary is formed by the upper part of the pedicle. Now the questions come, which triangle is safer? This triangle is safer or this triangle is safer? Remember, safe triangle is not safer. So if I draw in a different way, we can say if this is the imaginary nerve, then this portion we are having the safe triangle, but it is not safe as I am drawing in red, and one triangle remaining below. This is a comparatively safer triangle, that is the known as the Kambin's triangle. Okay, I'm drawing in green. But the question is, why safe triangle is called a safe triangle when I am talking that it is not safe? And the question also comes, why it is not safe? It is not safe because the reason behind is that the most of the segmental radicular arteries goes through this space. Remember, in old days that concept was not there, so this area is considered safe as this is away from the nerve. But actually, as there are the vessels that go, especially at the lower thoracic and the upper lumbar area, the largest radicular artery, which is known as the artery of Adam Quiz, that also goes through this area. So it is not a very safe triangle, but still the name remains the safe triangle. Whereas the Kambin's triangle is have been found a comparatively more safer triangle because here the nerve remains above, and also we are having the traversing nerve root going like this. So if we look at the root, so basically here we are getting a space between the exiting nerve root and the traversing nerve root, and it is not only safe for doing the transforaminal epidural steroid injection, rather it is also safe for the instrumentation like endoscopic discectomy. So nowadays most of the procedures is performed through the Kambin's triangle, not through the safe triangle. So that is the important. But for the diagnostic block or for only transforaminal epidural steroid injection, you can go for the safe triangle approach also. But remember, use a contrast agent that I have also told previously, and aspiration, both the techniques, to avoid intravascular spread. So how the vascular spread looks when it is intravascular? If you are giving a contrast agent and it is going intravascular, then the look will be, it's a simply vanishing sign because it is directly going into the vessels. So vessels will take the drug away. So it will be vanishing. So by that way, you can say it is being vanished gradually. Okay. Now coming to the step by step. So I have already told, first step is squaring. Next step is going to the oblique and finding the Scotty dog. And after putting the Scotty dog, you just put an opaque object over the area of your entry so that we can actually find out at what target you have to do. Once you got the target, in the next step, you have to put a needle. But before that, for example, if you have to go in certain level, for example, here or here. So first we'll be finding out at which level we have to go. And then after putting that marker, then I will go for the local anesthetic injection for the skin and the subcutaneous tissue, and usually beyond which no anesthesia is required because intramuscular area is usually pain free unless and until it is affected by the myofascial pain syndrome. That is another diagnosis that we sometimes found while doing a procedure because of the muscular spasm. But in most of the cases, usually anesthetize the skin and subcutaneous tissue with the lidocaine. Now, once it has been done, the most common needle used is the Quinky 22 gauge needle, and we should optionally paint the needle tip, and I do it always because it gives an advantage. If I bend the needle tip either towards or away from the notch of the spinal needle, then inside the body it is comparatively easier to maneuver. For example, if for say this side is the notch and I have bent the tip towards the notch side, so nip is like this. So what will happen? Within the body, when I will put the notch in one direction, the needle will automatically move to that direction. So it becomes easy to control the needle within the body, but it is not compulsory. But most of the pain physicians do it because in the deep area, sometimes it is very difficult only by changing the direction at the top. It may not be possible to reach the correct area. For that, we require this slight bend at the tip through which we can do small adjustments and go into the target area. And by seeing, and especially while going, we try to make it parallel with the image intensifier. So we have to understand this tunnel view concept as well. So what is tunnel view? So basically we are saying that Dr. I will show, we will try to make under the C-arm beam, our needle should look like a dot, not a line. That is known as the tunnel view approach. So basically the C-arm beam is going to a direction, and at the same direction our needle should go. So that we are actually only going on the Z axis, X and Y axis actually we have fixed. Now, once we have put the needle and we are thinking that we have close enough, then we have to go for the lateral view. Remember, some says that how we can understand that we are close enough. It depends on your experience definitely, based on the how obese the patient is. After going it certain distance and after making it tunnel, we should check the lateral view. Remember, every time it is not possible that we have gone inside and beautifully in the posterior part of the foramen, but in most of the time what might happen, your needle is ended here. So that is good, but the other thing you should not be wanting that our needle is going and they are hurting the nerve root. So we'll prefer to a posterior point, and after going there, gradually we'll try to be remain at the posterior part of this frame. Okay, so that is the foramen. So rotate the CM to a true anteroposterior view and check in both the lateral view as well as in the anterior posterior view, and advance the needle slightly just anterior to the facet and verify the needle depth in the lateral view, and then remove stellate and inject the contrast agent. Now for the injection of the contrast agent, the usual look of the contrast look like this, because it is showing the nerve root. So for the selective nerve root block, you have to inject a very small amount of contrast. For the transforaminal, you can go a little bit more, but here it should show the nerve root, that is the exiting nerve root as well as sometimes the traversing nerve root. Here you can see both the roots is seen. But if you give more volume, then definitely the other roots like the root in the opposite side, root one level above, one level below, they will also be seen. And remember, take 2-3 pictures, because sometimes it might happen you to understand that which type of distribution you are seeing. So this is the ideal distribution. So what is the ideal distribution in case of epidural distribution? In epidural distribution, it should be a heterogeneous distribution. See, it's an heterogeneous distribution because it is going to the epidural space, and there are, we are having the fats, we are having the capillaries, so it will not be an uniform distribution. It should be coming out through the nerves, because epidural space runs along by the side of the nerves along the nerve sheath. So it should be coming out through the nerves, and also it should be a patchy distribution. So these are the characteristics for an epidural drug spread, and we have to find out a proper epidural drug spread at this point. So we have to center the image, slowly inject the contrast under the live fluoroscopy, and analyze the proper contrast flow and contrast spread. That is very, very important. And adjust the needle and re-inject if needed. Sometimes it might happen, it is going to a muscle, it is not coming like this, so you can readjust and inject slowly. Another very practical tip here is that when you are first using in a patient, usually you do not use a concentrated dye first try to use a diluted dye. How much diluted? Usually we dilute the dye to 50%, so that initially if you are going in a wrong space, so it is showing a muscle or something else, so in the next time we can redirect and we can go with a concentrated dye. So in that case we do not have to cancel the case, but we will get the 2 attempt for a single time. Now once we are getting a good epidural contrast spread, then we should take the final drug. So what drug is taken? So I have already told, it is either triamcinolone, usually 20 to 40 milligram per root, and the total volume per root is usually 2 to 3 ml. So we have to add usually 0.5% lignocaine, usually in a very small. Remember here, whether you are using lignocaine, bupivacaine or ropivacaine is not having much value, because it is for the initial pain relief after the injection. But with time, definitely whatever local anesthetic you use, the effect will fade off, and ultimately it is the steroid and you're doing the procedure that will actually help in the longer run. So remember, here we have to add local anesthetic, but we usually use a low concentration local anesthetic at this point, because what will happen if you use a high concentration local anesthetic as if there is no problem, but only after the procedure you have to observe the patient for a longer duration of time, because initially there will be the weakness of the legs. If you the concentration is high, initially there will be loss of sense, but gradually it will return, because the local anesthetic effect will return, will end, and ultimately the effect in long run will be the effect of the steroid. So usually we say to the patients that usually after this injection you might get an initial pain relief which may last 1 to 2 hours, but after that the pain will come back, and from 3 days to 7 days your pain relief will start once over again, and which did that will continue. And sometimes this injection needs to be repeated, but usually it is repeated once. It is needs to be repeated, we repeat it after a month, and usually More than 3 injections per year is not recommended. So usually less than that is good enough. This is also a picture and distribution of the dry where the left-sided L5 transforaminal epidural is being done. So you can see the L5 route as well as the traversing S1 route. So similarly, so this identifying that these nerve distributions and routes are very, very important while we are going to perform this procedure. Now, can anyone tell what type of spread you can see? It's already written. So it's subarachnoid spread. So I have told you that the epidural spread is heterogeneous. Epidural spread is patchy. Epidural spread moves around the nerves. Okay. Here you can see this is neither of the characteristics are there. It's a homogeneous spread. It is actually showing a myelograph type of picture. Previous days when the MRI was not there, we have to find out the disc prolapse also. The dye is injected within the subarachnoid space, and then photograph is taken to find out the disc prolapse. The same picture you are going to see if you accidentally go to the subarachnoid space. So in our cases we do not want to go for these cases. And another thing is also important, it is restricted within the canal. It is not going outside like an epidural spread. So epidural spread comes out to the nerves, whereas it remains at the central portion or within the arachnoid part of it. Similarly, this is another kind of spread, but remember it's a very rare kind of spread and this cannot be done deliberately. So can anyone tell what type of spread is this?
It is
That's
intraspinal spread.
Subdural.
This is inside the spinal cord, probably.
No, it is not inside the spinal cord. So we have an epidural space that is above the dura. We have an intrathecal space that is below the arachnoid.
Subdural.
Yes, if there is a potential, there is a potential space under the dura and above the arachnoid, so that is known as a subdural spread. Now, characteristic of the subdural spread is that it is always accidental. You cannot deliberately put to a subdural space, and as this area is very thin, so small amount of dye will spread to a very large area. It's a paper thin spread, and it will not come out to the foramens. It will be along the lining and by the side. So this is one of the very important but ignored contrast spread, and it is possible to happen in case of spinal anesthesia as well, and sometimes especially in epidural anesthesia. If accidentally this type of spread happens, it can go a very high spinal anesthesia because of the large distribution of the large area. Okay, so it is an extremely rare spread, but it is not possible if you are using a blind technique. But when we are doing internal fluoroscopy, we can also detect this kind of spread as well, though it is very, very, or sometimes we can call it as an extremely rare condition. Now coming to the post-procedure advice. So what you are going to say to the patient? First, injection site care. No major injury is there, only a small foramen. So usually we put a band-aid there and ask the patient after going back home, just remove it, and usually there is a blood clotting and this usually doesn't cause infection or anything else. Then there may be a soreness in the back and sometimes pain. So we have to use ice or ice pack to manage this discomfort. Then always ask the patient before it, though in India it is not the very problem because most of the patient comes with the public transport or been taken by other persons. But driving precautions is very important. Just after the procedure, the patient should not go back home by driving by himself or herself. He should always take someone else for the driving. Then showering, the patient can take shower normally, so there is no post-procedure contraindication for taking showering. Resuming activities, the patient can gradually resume activities. Sometimes we call that on that day take a rest, but from the next day onwards the patient can, the comfort level reduces and the patient can work properly. And then in the meantime, if pain management is required, the most commonly we continue the anti-neuropathic medications what we have started before, and also we add paracetamol for the intermediate pain relief at this period. So that was the procedure, and Dr. Roy will be showing step by step way. But before that, if you have any questions, let me you ask me. Any questions?
Sir, what is the volume of the contrast agent that you take, and what is the volume of the
Yes,
local
that's a very
anesthetic?
good question. What's the volume of the contrast agent? Remember, it depends on how much experienced you are, because it is on your understanding that you are able to differentiate between a epidural spread, intrathecal spread, or subarachnoid spread. So usually at the beginning you might be giving 1 to 2 ml, but as you are being experienced and you are able to see these things, whether it is intramuscular or intrathecal or it is the epidural. So once you are confirmed, usually an average nowadays we use usually 0.5 to 1 ml of dye. More than that is usually not required in most of the cases. Here the picture you have seen, the L5 one, it is given just 0.5 ml of dye has been shown that much of distribution.
About the needles type.
About?
Needle using for the transforaminal.
I have already told the most commonly used needle is the Quincke spinal needle, 22 gauge. Sometimes 23 gauge is also used, but here 22 gauge is preferred because it's an optimal size between a very thin needle and thick needle. Because like spinal needle, we cannot use such finer needle like 25 or 26, because what happens? It is not stiff, so it is very malleable, and directing the needle becomes very difficult, number one, and the seeing the needle under fluoroscopy becomes difficult. So the optimal size is 22 gauge spinal needle, and that is most commonly used. And regarding the length, most commonly used is definitely the 8 centimeter, but in some patients we might have to take 12 centimeter or 15 centimeter needle if the patient is very thin, sorry, very obese.
Thank you.
Chinmada, can you start showing?
Yes. So I think you all can see the setup. I mean, here, okay. So this is a mannequin. This is a mannequin. This side is head side, and this side is hip side. So caudal side, cranial side. And think that patient is lying prone. So this side will be right side, and this side will be left side. So we will do the transforaminal epidural injection procedure. Okay. So first step, as I told you, the first step is from if right side is right side or not. Patient's right side and our on the screen also it should be right side. So you can see that right side is right side. So this is step one. Then comes step two, that our diagnosis part, that which area we want to see. So say I mean just an say this patient has right L4 radicular pain, and by MRI we have seen that there is a foraminal stenosis in L4-5 level. So for 4-5 level stenosis and right L5 radicular pain, we will go for the transforaminal injection also in the right L4-5 foramen. So which one is L4-5 foramen? So let us calculate. So this is the, I mean, this is the iliac crest. This comes between 4 and 5. So right L4-5 foramen means this part. Okay, between the right L4 pedicle and L5 pedicle, that is the right L4-5 foramen. Okay, so this is our target. So this is the second step. Now let us come to the third step. So third step is to understand, to see the spine in a tunnel view, in a Scotty dog view, but for making Scotty dog, first we have to see in a true AP view. So let us go for the third step. So shoot once. Okay. So here, actually we have in the third step means the pedicle and spinous process distance should be equal. This distance and this distance should be equal. So okay, earlier the, I mean, screen was I mean this X-ray was placed in this position. it looks like that this X-ray is in a, I mean, C-arm is in a typically AP view position. But problem is the inside the vertebra, it is a bit rotated. Okay, patient has say a bit of scoliosis. So that is the reason why this distance is a bit smaller and this distance is a bit bigger. So what we will do, we will just make oblique to the right side, a bit of obliquity. Yes. So a bit more. So this is the position actually for this vertebra for to see in AP view. Now we can see that this distance and this distance are perfectly same. Though we have not measured it, but it looks just by eyes, we can see with our eye that, I mean, this looks nearly same. So this is the L4 vertebra. So our target is that L4 vertebra should be at the in a true AP view. So this is the third step. Okay, pedicle to spinous process distance in both right side and left side is equal. Now comes fourth step. So what is the fourth step? Fourth step is end plate. So we will make these two lines of this end plate as one line. So since it is L4 vertebra, we will make a bit of cranial angulation. So though this angulation is called codocranial angulation, but in a short form for the technician, we will say that cranial angulation. So this is the angulation, I think a bit less. Let's see. Okay. So this is actually one line only. And this is here there is an artifact. This is a artificial disc we have made with something. So that's why this artifact margin is seen here. Otherwise, this is as far as end plate is concerned, this is a single end plate only. Okay. So with this angulation, we see the fourth step, and it is the same. Lower end plate is one line. So after the fourth step, now comes the fifth step to see the scotidog view. So since my target is in the right side, so I want a scotidog in this side only. I will say him to make the oblique towards the right side. Yeah, okay. Step by step. So here we can understand that this is the fourth vertebra, this is the fifth vertebra, and this is the scotidog. So here in scotidog, we can see both the dogs. Okay, here one dog, this is one dog, and this is another dog. Okay, where is the eye of the dog? So this part is the eye of the dog. Okay, this part is the eye of the dog. So here we know that when we can understand this dog picture, then we know that where is the foramen. So this part is the foramen between two pedicles. Okay, between two pedicles. So what is the margin of the pedicle? So this is one pedicle, and here this looks like another pedicle. Okay, the lower pedicle is a bit bigger and smaller, upper pedicle is smaller. So this is the end-on view of the pedicle. So here how much oblique we will do? We will do this much oblique that this facet joint line on the same side becomes we bring it to the half point of the above end plate. So say this is the half point. So it is nearly same. Or we can do one thing, that we can bring the, so two criteria, either this one is all right, facet joint to the half point, or this spinous process line, this is spinous process line, and this part is facet joint line, opposite side facet joint line and spinous process line, they come on the same line. They form one line. So any one we can take. So I think that we will take a bit more oblique, so that this joint line, facet joint line, comes a bit more oblique. We can do in the same line. So I have to go. Yes. So now we can see that this is the length of the lower end plate. This is the length of the lower end plate, and this facet joint line actually is making the lower end plate in two halves. It is breaking it in two halves. So it is in the middle portion. Okay. So now we can see the foramen very nicely. L45 foramen very nicely. So what we can see, though we are seeing only the bones, but in our mind we should imagine how the nerves are going through this foramen. So here one nerve is going like this. Okay. So it is going laterally also. It is going a bit forward also, from posterior to anterior direction also, and from medial to lateral direction also. So this is in this way the nerve is going. Okay. Let me put a needle to show you the path of the nerve. Okay. So more or less a bit this way. So this is the path of the nerve. So here let us think that okay, this is the way the nerve is going, but we want to infiltrate the steroid around the nerve in the foramen, but we do not want to touch the nerve or puncture the nerve. So we have two options. Either we go at the by the Kambin's triangle approach. So for Kambin's triangle, to identify the Kambin's triangle, we must identify this is the SAP, superior articular process. This is the ear of the dog. Ear of the dog. Okay. So we must identify the ear of the dog. And our point of entry is just lateral to the ear of the dog. So at this point, there is no bone. Okay, bone margin is here. This is the superior articular process or ear of the dog. So we are going just lateral to the ear of the dog. So remember, in Kambin's triangle approach, if you go too deep, then of course you will puncture the disc. So this is the disc space. Okay, so you will puncture the disc. So this is a negative point. But what is the positive point? Positive point is here there is less blood vessel. So blood vessel can be there everywhere, but then still this is the safest area where blood vessel is very less. Okay, so this is the triangle. This is the triangle which we call as Kambin's triangle. So one side by the lateral side of the SFP, another side is the upper margin of the vertebral body, and another side by this exiting nerve root. Okay, so we will target here for going in the foramen in the Kambin's triangle approach. Okay. Another one, another one which was earlier very popular, so that is subpedicular approach. Still, you can go for it. There is no, there is no contraindication or such as such. That is not something wrong. So that is subpedicular approach. So where it is done? So pedicle starts from here to here. Okay. So just mid. So if I compare that it is a face of a clock, then where is the 6 o'clock position? 6 o'clock position is here. Okay. So just at the 6 o'clock position means middle of this width, middle part of this width here. So under the bony margin. Under the bony margin at this area, I will put the needle. So this Kambin's this subpedicular this is the sub area for injection of the subpedicular approach. Okay. Earlier it was called that safe triangle approach. So here is the safe triangle. So this one lower border, and one side is this one, another side is this one. Okay. So this one was safe triangle, but nowadays its name is I mean it is just for the name, otherwise it is not safe, because here if you inject, more blood vessels are there. Okay, so this is the disadvantage of injecting in this place. But what is the positive point? Positive point is, if you go more deep, then also you are not entering in the disc, you will hit the posterior part of the vertebral body. So this is a positive point, because entering in the disc itself increases the chances of infection, and otherwise it becomes a bit more painful also. Okay, so both the procedures can be done either in subpedicular approach or in the Kambin's triangle approach, and both will I mean infiltrate the drug in the same area only. So let us go for the both the procedures here. So I will go here, maybe so just at the tip position I will inject. Wait, and needle is bent actually. So let me check again whether my entry point is correct or not. So entry point is correct. Here I am going a bit laterally, so I have to go a bit more medially, and I have to go a bit down. Okay, so here is the Wait. Okay, give. Okay, I will put another needle in the Kambin's triangle approach. So that one is here. Okay, so just lateral to the tip. So So lower one, so the Kambin's triangle approach, that one, it is nearly it is a tunnel view approach. Okay, because we are seeing, just a minute, this needle is changed its position. Okay, sure. Okay, so this is the nerve root is going in this way, and both these needles are placed up to a depth. I am not sure. So this is more or less a tunnel view approach. This is more or less tunnel view approach because it should be a one dot like. So if you are 100% tunnel view, then we will see that only one dot like. That is our intention, but every time we may not get that. And this is not tunnel view, but still it is also not a, I mean, close to a tunnel view because long needle has become this much only. Okay, so this is the oblique view. Now we will see in a AP view. Now we will see in a lateral view first that what is the depth. We will see the depth first. So yeah. Okay, so both have actually reached. So in a normal patient, we will always think twice before going so much of depth. Maybe we can go up to this much and then should say this much only maximum. Sometimes you may have if you do not know that how much is the depth. I mean, you cannot anticipate in that way, so you go up to this much also is okay. I mean, there is no point going more and then coming back, so that is not acceptable. You should be always I mean, posterior, in the posterior part of foramen. So this much is my target. I can go up to this much. If I go more, then if I go in the Kambin's triangle, I have the possibility to puncture. And here, of course, if I go more, there is no such issue, but still I don't want to puncture the root. So in lateral view, after seeing this much, I will again go a bit more, and this side also I will go a bit more. So okay, so both are in the right position. Okay, so this is the perfect position in lateral view. Okay, now we will see, this is the last position in the lateral view. Okay, L45 foramen. And now I will see in the AP view that what I can see, that whether it is in the foramen or not. So in this view, in lateral view, we understand that how much deep we have gone. So anterior and posterior thing is becomes clear to us. But in AP view, what has to be clear is your medial or lateral position will be, you will know that your needle is medial or lateral to the foramen. Okay, should. So here, so in this view, we can see that how much medial or lateral. So a bit of, we will see in a true AP view. So this is the true AP view in the L45 foramen. Okay, so here we can see the needle in the upper place or lower one, both are in the right place because this is the pedicle and this is the pedicle. So foramen starts from here. Okay, foramen starts from here and up to here. So it is below the pedicle. So both sides it should be below the pedicle. So your tip of the needle should come just, it should cross the lateral border of the pedicle. It should come medial to the lateral border of the pedicle. Otherwise you are outside. Okay, so I could have gone a bit more medial also, but it is okay. Here also I could have gone, but still this is the lateral border of the pedicle and your tip should come just medial to the lateral border of the pedicle. So you are under the foramen. Because why we stress that this needle tip should come inside the foramen? Because otherwise, once you give contrast, the contrast should go like this. Okay, but a lot of contrast may go outside the foramen like this. Okay, so your needle tip should come within the foramen, and the width of foramen or the margin of foramen is determined by the margin of the pedicle, lateral margin of the pedicle. So this is the foramen line. Okay. Any question here?
When using the Kambin triangle, is it better to square the L5? Because we squared the L4 first. We have the Scotty dog very clear if we use the safe triangle, but when we use the Cambian triangle, the L5 Scotty dog was not as clear as L4.
Oh, no, the one of them is okay. I mean, you want the like this space. I'm considering this space is my area of interest, okay, target of interest. So this end plate, the upper end plate of L5 or lower end plate of L4, both are very near. You can choose any one of them actually. Both are very near. So both will have the same result only. I mean, it is not much important here. Okay, you can choose anyone, but then main problem is that if you choose this one, then you are seeing the L5 in a true epi view. If you are choosing this one, then you are seeing the L4 in a true epi view, and both have some what should I say? Some degree difference in their angulation. So okay, this is also not. I mean, it is also possible, but I think this much angulation doesn't matter. Usually, we do in the L4 upper one end plate only. We go for the making them the single line. Okay.
Thank you.
Excuse me, sir. If we are doing for L5 radiculopathy, the same previous doubt, can we use Kambin triangle approach?
L5.
L5
Why not?
between L5 and S1.
Yes. Why not? Why not? Here actually I can try to show here also, but then
Yeah.
this is not a normal. I mean, like actual human body. What we have made is this one is too much carved. Okay, L5. So you can see how much angulation we have made to make the L5 lines one line. Okay, so this is also possible. Someone may have this much of angulation. So now the same thing, the formula is same. With the same this kind of cranial angulation, we could achieve the L5 lower end plate as a single line. Okay. So after that, say I want to inject in the right side. So I will tell him to make angulation on the right side, oblique. So I expect that here in this area, the triangle should come. So I will tell him to make the angulation a bit more. Okay. Okay. Anyway, so yeah, okay. So in this position, what I am seeing this is one dog. This is one dog. Okay, but here dog is not there because sacrum has started, but ear is here. If it is the ear, then this part should be the nose. Other part is not there, but this ear is important. So just at the side of the ear, in this portion, if I inject, I will surely go in. This is a Kambin's triangle approach, and if I go too much, then I will go inside the disc actually. So you can see if I put the needle here, then I show you. So just Hmm. Hmm. Okay, at the tip. So I have to make a tunnel view approach. Okay, this has to be a tunnel view approach. So I will check in both the views. Shoot. So I am going a bit caudal. I have to make it a bit cranial. So with this, so still a bit caudal. Okay, so this is more or less perfect. Tara. Should. This needle is a bit bent. So, okay, I mean, it is going in the right direction. So up to this much I have gone. Now I will make it a lateral view. So shoot in lateral view. In a lateral view. So I will see in a lateral view that how much I have gone. Okay, so so I have gone a bit more. That much is not needed. So okay, so this is the perfect view. Okay. So this is the perfect view in the lateral position. Shoot again. So you can see that it is in the epidural. This is a continuation of the epidural space, no? Caudal epidural space also in the same continuation. The needle should come here. So in this view, it is a bit difficult to understand that which is the SAP in this area. Otherwise, we can understand this is the SAP. So here also SAP should be in this area. So it is just in this position. It is the correct position. And if you go more, then of course you can go inside the disc. So this is the Kambin's triangle approach. And if you want to go in a subpedicular approach, then your needle has to come in this way. That the needle has to come in this way. Okay. Every time you may not get space for subpedicular approach in this area, but Kambin's triangular approach, most of the time the space is there. Okay.
And sir, if we initially will be scared to go more deep, and if we stop too much superficially, and we took a lateral view, understood that it's too superficial. Can we come back to this oblique view? We can't.
Yes, of course. It is better. It is better to come back in the oblique view and then go a bit more. Say in lateral view, you see your tip is here. Of course. Then if you go more, then it will change the path. Okay, this much depth, it can change the path if you go in a oblique, this lateral view. So you come back to the oblique view, Scotty dog view, and then you go up to this much, then again come in the lateral view. Okay, that will be better.
Is it possible, sir, to get the same tunnel view again, coming back to the same obliques? It was a difficult initially.
Yes. No. Same oblique you will get, of course.
Can get. Okay.
It's very easy.
Okay.
That is
Thank
very
you.
easy. Okay, so this much only. I think nothing more. Any other question?
We have the quiz.com.
Yes. No, you are starting?
Yes, I'm starting.
Okay.
Nanometer. Lena Reader, Queen. Uncle Fork. Jazz, Quick Boy. Surf Phone. Drass. Kaushik Kanakaraj. Slow Lion. A Haunted Brother Snail. Wild Mama Queen. Toilet Cow. Jolly IQ. Uncle Slow. Dr. Cow.
Okay, let's start.
Quiz.com. Play and create.
The needle is positioned in
Lucky flower joined.
L4 nerve root. Which nerve root lesion causes sensory loss in the medial portion of the leg? L5. Which nerve root is associated with the Achilles reflex? S1. The contrast spread in the picture shows subdural spread.
Papa Hacker 1 joined.
Arrange in the correct order the steps of transforaminal epidural steroid in (1) Initial X-ray for area identification. 2. See arm oblique positioning. 3. Needle placement. 4. Epidural contrast injection. What is a major advantage of transforaminal corticosteroid injection over interlaminar admission? More precise delivery to the inflamed nerve root. Which nerve root lesion affects the dorsum of the foot and first toe? L5. Patient positioning for lumbar fasces requires prone position with an abdominal pillow. The recommended angle of C-arm positioning during needle entry for the lumbar fascia procedure involves cephalad/caudal tilt and oblique positioning to affected side.
Final question. Double points.
Verification of the needle position during the lumbar fascia procedure requires
H joint.
true anterior, posterior and lateral views.
Third place, Drass. Second place, Brother Snail. And the winner is Uncle Fork.
So who is Uncle Fork?
Sir, myself.
Okay, you confess constantly throughout from the beginning, remained at the top. Congratulations.
Thank you, sir.
Okay, let's end today. The questions are already given and the study material is already posted within the group. Okay, so let's say bye-bye for today.
Okay, bye bye. Good night.